Edward B. Lee graduated Phi Beta Kappa and with honors from Stanford in 1997 and obtained his MD and PhD degrees from the University of Pennsylvania in 2005, where he studied amyloid pathology in various experimental models under the mentorship of Virginia M.Y. Lee, PhD. After clinical training in anatomic pathology and neuropathology, Edward was appointed assistant professor in 2011 and promoted to associate professor with tenure in 2021 in the Department of Pathology and Laboratory Medicine at the University of Pennsylvania. Edward is currently principal investigator of the Translational Neuropathology Research Laboratory, supporting studies on the molecular neuropathology of Alzheimer's disease, frontotemporal degeneration, and amyotrophic lateral sclerosis, recently discovering a novel form of dementia called vascular tauopathy. He is also an attending physician at the Hospital of the University of Pennsylvania, co-director of the Penn Institute on Aging, director of the Penn Center for Neurodegenerative Disease Research Brain Bank, and associate director of the Penn Alzheimer's Disease Research Center.
Great, thank you so much. I appreciate being able to talk to everybody. So today I'll be talking about Alzheimer's disease and also try to add a little bit of complexity in there because it's the more you learn about this disease, the more complicated it gets. So here are the session learning objectives that we already went over. And so I'm a practicing neuropathologist. I also run a research lab. I'm most interested in neurodegenerative diseases. My lab does a lot of research on the frontotemporal dementias and related disorders, the inclusions which are shown here. Today, we'll really focus on Alzheimer's disease, which is classically, amyloid plaques shown on H&E by immunostain and neurofibrillary tangles here. This is a thioflavin stain of a neurofibrillary tangle. And so one way to approach this is kind of just to memorize everything, right? The different neurodegenerative diseases have different lesions that you could identify in the brain, and these are made of different types of proteins. And this will get you, 80% of the way there, let's say, but it doesn't add the complexity that there's a lot of heterogeneity with this disease, a lot of comorbidities, and a lot more nuance than is typically presented when we're talking about the neuropathology of Alzheimer's disease. So this talk is divided into several parts. In this first one, we'll talk about the pathologies that are specific to Alzheimer's disease, so ADNC, Alzheimer's disease neuropathologic change. And I thought a good place to start is to first discuss what is dementia and what's the definition of dementia. And so this is something that I think is useful as a definition, in that dementia is progressive and is a progressive and irreversible syndrome characterized by cognitive dysfunction, typically over multiple cognitive domains, resulting in impairment of activities of daily living. And so if we break this down a little bit, progressive, right, and irreversible is a feature of dementia. And if you want to compare that with, for example, let me get my pointer, with delirium, right? Because delirium is not necessarily progressive and is reversible, right? And so if somebody's in the hospital and they sundown when it gets dark and they get confused and agitated, you could consider that delirium, but the next day they might rebound. And so that's not technically dementia. It affects cognitive function. And notice that there's no mention of the word memory in this definition. People often equate dementia with loss of memory, and that's not necessarily true. So if we think about, there's this famous patient, HM, and he had these bilateral hippocampal removal surgeries, right? And he had horrible memory, but we didn't consider him to truly have dementia. Cognition is broadly defined, and we'll talk about their different cognitive domains, and many of these are affected in Alzheimer's disease. Although the typical memory complaints and amnestic phenotype is the most common and most prevalent form of dementia. And it has to be severe enough that it affects your ADLs, or your activities of daily living. There are precursor states, such as what we call mild cognitive impairment, where you can have cognitive dysfunction, but it hasn't progressed to the point where it's affecting your daily life. And so dementia is technically once you have that functional decline. And so with that definition, there are many different ways you could get to dementia. And truthfully, end-stage dementia can be difficult for clinicians to decide what type of dementia it is because they're so impaired that it's difficult to really assess. So if you kind of back up in time and you look at what are the predominant earlier signs of neurologic dysfunction, there are different ways you could get there. And so if we talk primarily of an amnestic or memory dysfunction leading to dementia, end-stage dementia, and this is what we classically think of Alzheimer's disease, where you have in the brain amyloid plaques and neurofibrillary tangles. But there are other types of dementia. So classically, a stepwise neurologic decline is what we think of a vascular type dementia. If you have more behavioral, executive, or language dysfunction, these are what's considered to be frontotemporal dementias. um, Even motor neuron disease, so you could have motor symptoms, and many of those individuals with like ALS or Lou Gehrig's disease will progress to form dementia, and that's a different type of dementia, probably more in the FTD spectrum. And even people with a movement disorder, so people with Parkinson's disease, many of them progress to develop dementia as well. So today we're mainly talking about Alzheimer's disease, but we have to know that dementia is pretty heterogeneous, with a bias out there that thinking about memory just because Alzheimer's disease is the most common dementia. And so Alzheimer was a physician, and he recognized this in this individual, Auguste Dieter. She did have severe memory deficits. This was over 100 years ago. But also had speech difficulties, had perceptual abnormalities, having hallucinations and delusions. And again, that's speaking to the fact that Alzheimer's often picks off multiple cognitive domains. And she died due to complications of a decubitus ulcer. An important note there is that many times, or for a long time, Alzheimer's disease was underappreciated just because the way that we fill out death certificates, we would say, for example, in this case, we might say she died of sepsis secondary to a decubitus ulcer, but the reason she has the ulcer is because she has dementia. And so now modern death certificates are much better at outlining what are the contributing causes. And so Alzheimer's disease is obviously much better recognized as a cause of morbidity and mortality. And interestingly, she died when she was 51 years old, which is relatively early. Early onset Alzheimer's disease is defined as somebody who develops the disease before age of 65. So she had early onset Alzheimer's disease, and years later, we realized they were able to find her materials, and they found that she actually had a mutation in a gene called presenilin 1. So I'll just talk a couple sides on the genetics of Alzheimer's disease. Again, if you think about the early onset forms of Alzheimer's disease, sometimes these are associated with various autosomal dominant causes of Alzheimer's disease, the most common being presenilin 1 mutations, but some of them might have mutation in presenilin 2 or the amyloid precursor protein. And all these mutations serve to increase either the amount of beta amyloid you're making or the type of beta amyloid, so that it's more aggregation prone. But by far and away, the most common form of Alzheimer's disease is late onset. And there we now know many genetic factors that are risk factors for Alzheimer's disease. So they're not autosomal dominant. The strongest risk factor being variants in the ApoE gene. TREM2 variants are rare, for example, but have a pretty strong effect on Alzheimer's disease and others. And so this is a meta-analysis of all the genome-wide association studies. And you can see here, these are all the different genetic loci that have been associated with increased risk for Alzheimer's disease. You can see that ApoE here has a very significant risk for Alzheimer's disease, along with some others here. The general one general theme that's coming from these genetic analyses is that microglia and innate immunity seem to be causing or contributing to Alzheimer's disease, I should say. Okay, so let's move away from the genetics and get into the pathology. So on the top here, we have an Alzheimer's disease brain. On the bottom is a normal brain. I'll say that, so the leptomeninges are still here. I actually like to keep the leptomeninges because sometimes you could see disease processes going in there. And if you strip it off, you might lose things like metastases or other tumors or other inflammatory conditions. But you could see that there's essentially generalized atrophy. You could see this fissure here is very wide open, that the gyri are not very packed back to back, and that's compared to a normal brain. A relatively subtle finding is that the atrophy here, you could see, tends to be more in association cortices. If you look at the primary motor and primary sensory cortex here, they seem to be relatively less affected, but that's a relatively subtle finding. Truthfully, if I see this type of brain on the top, it could be compatible with dementia. I've seen some elderly brains that look atrophied like that might not have a lot of cognitive symptoms. So it's not very specific. There are other dementias such as Pick's disease, for example, that have this profound atrophy, which is a lot more characteristic than what we see here. And this is just a side-by-side comparison. This brain here on the right is an Alzheimer's disease brain. This brain here on the left is a normal brain. You can see there's general atrophy. The ventricles here are slightly larger. The hippocampi in particularly are very small. And so this is just a clue for Alzheimer's disease. Truthfully, though, the mainstay of dementia diagnoses now is microscopic. And in the setting of Alzheimer's disease, we're talking about the two major lesions, which are one, neurofibrillary tangles. These are intracellular protein aggregates. The aggregates are made of these paired helical filaments that we could see by electron microscopy. And those filaments are made from a protein called tau. Tau is a microtubule-associated protein. It binds to microtubules and stabilizes them. In the disease, the protein becomes abnormally hyperphosphorylated, becomes insoluble, and forms these filaments that fill both the cell bodies and all the neurites, the dendritic processes as well. The second lesion are amyloid plaques. These are generally described as extracellular. I'll talk a little bit about plaques because they're actually a complex lesion. But the extracellular deposits are made of this protein or this peptide actually called A beta or beta amyloid. This is, an up to 42 amino acid peptide. There's an amyloid precursor protein, which is cut by various cellular proteases that secretes this protein. And in the setting of Alzheimer's disease, we see this coalesce into these amyloid plaques. And again, just like the tau protein becomes insoluble, this A beta peptide also is very insoluble. So this is what a neurofibrillary tangle looks like on H&E. I'd say this is a well-formed one. Some of the other neurofibrillary tangles can be very difficult to see on H&E, but you could see this basophilic material kind of filling the cell body, almost like a flame shape type morphology. And really, though, it's not very sensitive to see these by H&E, and so we do immunostains for phosphorylated tau protein, and we could see different lesions. One are the cell body associated aggregates. These are the neurofibrillary tangles, but in the background, all of these squiggles in the background are the neuritic threads, also filled with these paired helical filaments made of tau protein. Quantitatively, the amount of tau that's building up in these neurites actually outnumbers is a greater burden than the actual neurofibrillary tangles in cell bodies. And so the thought is that both are contributing to disease. And these are the paired helical filaments that I was mentioning. So we could see these by electron microscopy. This is an old study from the 80s where they purified these proteins, and you could see these beautiful paired helical filaments. They're forming twisted filaments here. So the tau protein is encoded by the MAP tau gene. It's on chromosome 17, sorry. Normally it binds to and stabilizes microtubules. In the setting of disease, it becomes insoluble. It's found in cell bodies and dendrites, and it's hyperphosphorylated. And so you could use phospho-specific antibodies to better identify these inclusions. And it's thought that the protein itself is kind of choking the cell body and impairing cellular function. And it also means that the tau is no longer able to bind to and stabilize microtubules. And so there could be these loss of function mechanisms as well. And I won't talk too much about this, but there's now cryo-electron microscopy methods where we could get really, really fine structural detail about these filaments. And so here's a reconstruction of the paired helical filament. If you take a cross-section, we could see this double J structure. So this is the core of the filament. And now we know exactly how each amino acid kind of lines up to form a protofilament, which is one of these structures. And then the filament itself is made of two of these protofilaments. So this is the core. the filament. Outside of the core are other parts of the protein that are kind of flopping around, and that's called the fuzzy coat. But these are the building blocks of neurofibrillary tangles and the neuritic threads we see in Alzheimer's disease. Okay, let's talk about the amyloid plaque now. So the amyloid plaque is even more subtle on H&E. You could see kind of maybe this waxy substance here, kind of look bulbous in some areas, and then sometimes you see these more linear, more purplish structures. So the purplish structures here, the more linear ones or wispy ones, are actually often filled with tau protein. So the neuritic pathology is accentuated inside of an amyloid plaque. And you also see these really small cells here, which are probably microglia, maybe astrocytes, that are honing into the microglia or to the amyloid plaque and reacting to the amyloid. And just an aside, so I published a review in JNEN, our society's journal, and this is what one of the reviewers wrote to me. And he said, plaques are not made of tau, because I said, you know, Alzheimer's saw tau inside amyloid plaques. And he said, plaques are not made of tau. The 50,000 or so people working on the amyloid cascade hypothesis would consider this statement highly incompetent. To say that Alzheimer's saw plaques and tangles where neurons had once been is equally incompetent. And truthfully, I'd never been called incompetent once, let alone twice in one sitting. So just to show you guys, this is Alzheimer's original description, and these are the images that he provided of what now we know are amyloid plaques. And you could clearly see that you have these dystrophic and swollen neurites that are intimately involved with the Alzheimer's disease plaque. And so, yes, amyloid plaques are made of beta amyloid, but they're complex structures where tau is coming in and becoming hyperphosphorylated and aggregated. And so this is another immunostain of an Alzheimer's disease brain. And again, you could see the tangles and you could see these dots and stipples and linear things in the background. But these clusters of these dystrophic neurites are the dystrophic the dystrophic neurites filled with tau aggregates that are associated with amyloid plaques. And so these are what we consider neuritic plaques, and they're neuritic because the intracellular dystrophic neurites are associated with these extracellular beta amyloid plaques. Now, not all neuritic plaques stain for phospho-tau. Part of that is because some brains have so much phospho-tau pathology, it's hard to pick these out. So we do routinely do immunostains for beta amyloid, and this is just an example where you could see these beta amyloid deposits. Again, these are short amino acid peptides cleaved from the amyloid precursor protein gene that deposit in the extracellular space. The same peptide, I don't have a picture here, can also build up in cerebral blood vessels in what we call cerebral amyloid angiopathy. So CAA is a very common observation in the setting of Alzheimer's disease, but of course we know that CAA can also happen outside of Alzheimer's disease and cause these devastating lobar hemorrhages because the vessels become fragile. So amyloid plaques actually have a very diverse morphology. There are very different types of amyloid plaques. So you can have what look like more diffuse amyloid plaques. And these typically, I mean, you could see these in normal individuals. You could see some of these in Alzheimer's disease. They're thought to be not that pathogenic, relatively innocuous, whereas other plaques have a more compact appearance, or this is what we call like a mature amyloid plaque with this very nice formed core with this kind of halo of amyloid around it. Other techniques instead of immunostain, you could do things like a thioflavin stain or a silver stain. Here you can see the amyloid plaque. Thioflavin helps because you could also pick up the neurofibrillary tangles. The other benefit of thioflavin is you actually start to pick up the dystrophic neurites. Again, many of these are filled with tau protein that are associated with amyloid plaque. And so this is a nice image of what we would consider to be a neuritic plaque, which is the key amyloid plaque lesion seen in Alzheimer's disease. So thioflavin and other related molecules, I'm just showing you one here. Those have been modified by scientists to develop various imaging agents. And so if you take derivatives of that compound and radio label them with various radio tracers, and then inject that into individuals. You could do a PET scan. You could see this is a normal individual who looked negative by PET, amyloid PET, and by postmortem exam, really had very little amyloid plaques, whereas this person intermediate, this person has a lot of amyloid PET tracer uptake. You can see at postmortem, they had a lot of amyloid as well. Just to mention, this was led by Chris Clark, who I worked with many years here at Penn, and also led by Dan Skowronski. And he was actually a neuropathologist, and he used his insights of neuropathology to develop these amyloid PET imaging ligands. So there's amyloid PET, tau PET is coming online as well, and there are other various biofluid markers, so CSF, and now plasma is really being studied intensely, that we should be able to, in most cases, determine whether somebody has amyloid, for example, before they even come to autopsy at a certain level. And so that has added benefits that when you see cases at autopsy, I think over the next decade or so, many of them will have ante-mortem, either PET or biomarker data, which will help in your diagnosis. And I was joking here to say thank you, that's it, but that's just the beginning of the talk. We'll talk next about how do we use all these lesions that we're identifying to determine how much Alzheimer's disease path change you have. And so that's the NIA-AA, so National Institutes on Aging and Alzheimer's Association criteria for diagnosing Alzheimer's disease. And so just to back up, there have been many different versions of the Alzheimer's disease neuropath criteria. This is the most recent one that came out in 2012. But if you go back in the literature, you might be a little bit confused because some of the older ones use different criteria. And the important thing with the most modern criteria is really a conceptual change, where previously we used to say, we see plaques and tangles to a certain amount. What are the chances that the pathology we see at autopsy correlates or is associated with Alzheimer's type clinical Alzheimer's disease? And so we previously said, oh, this has an intermediate probability of being associated with dementia or Alzheimer's type dementia. What's changed now is that we just report on the neuropath side the amount of AD neuropathologic change we see, irrespective of clinical data, right? So we say there's no ADNC or low, intermediate, and high level of ADNC. So it's irrespective of the cognitive phenotype. And the analogy here is that we as pathologists can describe, this case has a certain amount of atherosclerosis, right? We describe that even irrespective of whether the person had angina or a myocardial infarction. It's just what we see. And so that's what we do now for Alzheimer's disease. And the presence of this pathology now defines Alzheimer's disease, irrespective of clinical syndrome. So that allows us to say this person has a certain amount of Alzheimer's disease, neuropathologic change. If they don't have cognitive symptoms, then we consider that to be a preclinical state. Just like, again, you could have a certain amount of atherosclerosis, not yet have a heart attack, but we still think that's heart disease or coronary artery disease. So the way we do this is we come up with an ABC score. So the A score is for amyloid, and this is something called the thal phase, and we'll go over this. B is for tau, and that's a Braak stage. And C is for CERAD, which is a score of neuritic plaque density. And so we'll go through each of these. The Braak score is probably the most complicated, so I'll start there. And this is based on the work by Heiko Braak, who has this amazing brain bank where he's doing these whole mount sections. So these are whole mounts of the human brain, and he stained them for tau or phospho-tau, and he defined 6 stages of neurofibrillary tangle distribution and degeneration. And so stage 1 is really here at this transentorhinal cortex region, whereas in stage 2, it kind of goes from there and spreads into the hippocampus. Stage 3, it's kind of escaping the hippocampus into the rest of the inferior temporal lobe. Stage 4, you can see the medial temporal lobe is pretty much, fully affected, and it's starting to escape a little bit into other cortical areas, where stage 5 and 6 progressively hits more and more cortical areas. And so schematically, that's kind of shown here. You kind of start in the medial temporal lobe, in the transentorhinal and entorhinal cortex, again, spreading to the hippocampus, out through the temporal cortex into the rest of the cortex. And this actually correlates very well with what we think of as classic Alzheimer's disease, meaning Alzheimer's disease classically is a strong amnestic or memory problem, which correlates with the hippocampus being involved very early. But as the disease progresses and you develop full-on dementia, you start developing other symptoms that are related to other cortical functions. So that reflects the tau spreading into the rest of the brain. So what does this mean practically speaking? Because we're not going to do the whole amounts that Brock did, or assess all those regions. And so what I often do is kind of look at 2 main sections. This is how way I do it. Other centers might do it differently. And if we're talking about Brock 1, if you're taking the hippocampus at the level of the lateral geniculate nucleus, there's actually no entorhinal cortex or transentorhinal cortex in this section. But once I start seeing some pathology here, I'll call that a BRAC 1, and I'll call BRAC 2 when it starts to creep into the hippocampus. BRAC 3 is when both the hippocampus and the parahippocampal gyrus is involved, right? You could have a little bit of involvement beyond the collateral sulcus into the temporal neocortex, but it's mainly centered in the hippocampus and parahippocampal gyrus. And then BRAC 4, this whole section should be pretty much involved. And at this point, you cannot tell really whether it's BRAC 4, 5, or 6, right? And that's where I turn to the visual cortex and the peristriate cortex. So if you take a section, I have to fix this. With visual cortex and then the gyrus under. So if what I'm trying to show here is this is visual cortex, and then inferiorly, BRACs 0 through 4 really shouldn't be involving the visual or peristriate cortex. BRAC 5 is when you start to involve the peristriate cortex, and BRAC 6 is when the primary visual cortex is involved as well. Again, there are different ways to do this. Some people rely more on the hippocampus. Other people do neurofibrillary tangle counts. There's a lot of ways to potentially interpret BRAC staging, but this is, I think, a simplified way that I use, using just these 2 sections. The other thing just to keep in mind is that there is a biochemical classification of tauopathies as well. Tau is a complex gene that is alternatively spliced. You have these N-terminal acidic domains, which you could have 0, 1, or 2 inserts into this N-terminus. And there are microtubule binding repeat domains. So again, tau is a microtubule binding protein, and you could have either 3 of these repeats or 4 of these repeats expressed. And what we do for tauopathies is we concentrate on these repeats, and we say, is there 3 repeat or 4 repeat tau? And there are ways you could do this biochemically, but in essence, Alzheimer's disease is characterized by the accumulation of 3 repeat and 4 repeat tau. And that's in contrast with other diseases like Pick's disease is mainly a 3 repeat tauopathy. Progressive supranuclear palsy and cortical basal degeneration are 4 repeat tauopathies. Understanding that most labs don't have the biochemical methods to characterize this, if you really want to go down that route, there are antibodies that specifically recognize 3 repeat tau only, and there are antibodies that recognize 4 repeat tau only. In most cases, I would say that is not necessary to make a diagnosis. But if you really, were confused or not clear about which type of tau there is, you could use those antibodies, and it'll give you clues of what the underlying biochemical classification is. Okay, so that was BRAC staging. So that's a B score. A score stands for Thal phases. So Dietmar Thal published this paper where he said that there are different phases or regions involved over time in Alzheimer's disease. So phase 1 is when neocortex is involved and not much else. You could have, just essentially cortex only amyloid. Phase 2 is really when it starts to hit medial temporal lobe. So you start getting hippocampus, and maybe some amygdala. Phase 3 is when it hits the diencephalon, so you start getting, the striatum and thalamus, for example. Phase 4 and 5 is when it really spreads all the way down into the brainstem and even the cerebellum. And so phase 5 is essentially when it hits cerebellum. An important note for thal phasing is this is based on all amyloid. So diffuse amyloid plaques, neuritic amyloid plaques, dense cord plaques, anything counts. And that's important because for example, the amyloid you see in the cerebellum in phase 5 typically is not very dense. It tends to be this wispy diffuse type amyloid. So this is just a measure of how far throughout the brain has amyloid spread and how much do you have in a regional manner. And so this is an example here of the amyloid you could see in the cerebellum. You have also, again, commonly you could see cerebral amyloid angiopathy. I do not use cerebral amyloid angiopathy for thal phasing. So if you have isolated CAA in the cerebellum, that is not enough for me to call it a phase 5. You really have to see these parenchymal deposits in the cerebellum. Interestingly, a lot of times you get these kind of linear streaks that go perpendicular to the peel surface. And that probably has to do with the fact that your Purkinje neurons have these dendrites that kind of go up, that kind of are shaped like a fan, and it kind of directs the amyloid in this very linear projection to the peel surface. And then finally, C is for CERAD. So CERAD is a consortium to establish a registry for Alzheimer's disease. So that was in the early 1990s, and this was one of the original diagnostic criteria for Alzheimer's disease. And they said, if you look at neocortex, so not allocortex or other regions, so you can't look at cingulate gyrates, for example, but if you look at neocortex, you give it a score being, sparse, moderate, or frequent. And this is specifically looking at neuritic plaques. And so you ascertain how much neuritic plaque in the neocortex you have. So it's a severity score, not necessarily a distribution score. There are different ways to classify a plaque as neuritic. Thioflavin is a nice way. Silver stains work as well. Because these are extra stains, in our lab, we do an amyloid stain and a tau stain. And based on the tau and the amyloid, you kind of estimate how much neuritic plaque you have. It could be a difficult exercise, and I'll say, behind closed doors, when they were developing the newest criteria, there was no consensus on how to specifically identify and call neuritic plaques. And because of that, there are no specific staining requirements. If you understand that plaques are complex structures that sometimes are filled with dystrophic neurites, you could use different methods, like I said, thioflavin, silver stain, tau stains, amyloid, or a combination of those to estimate the amount of neuritic plaque pathology you have. Now that you have these A, B, and C scores, you essentially can go to this table and decide, is it not Alzheimer's disease, meaning there is no amyloid? So you definitely need amyloid in order to call it Alzheimer's disease, or is it low, intermediate, or high level of Alzheimer's disease? Now, low level of ADNC is typically not associated with cognitive phenotypes in living individuals in isolation, right? So if you have, other diseases, let's say you have really bad cerebral vascular disease, then maybe a low level of ADNC can help contribute somewhat to dementia, but on its own, it's usually not. High ADNC is most often associated with cognitive phenotype and dementia. Intermediate, it's kind of intermediate. So some of those individuals have full-blown dementia. Some on the lower end might have just mild cognitive impairment, and some might actually be normal if they're kind of on the edge of intermediate ADNC. Okay, so that's Alzheimer's disease and ADNC and the criteria. Next, I kind of want to add a little bit more color, which is talk about heterogeneity of Alzheimer's disease. So I'll go back to this diagram where we said there are many ways you can get to Alzheimer's disease. Sorry. Sorry about that. I just pulled out my microphone. there are many ways to get to dementia, and classically we kind of think of these as separate diseases, but now we know that in the setting of classic Alzheimer's type dementia, you have amyloid and you have tau, but you can often pick up some of these other types of pathologic inclusions. And so we'll talk about some of those. But just to show you, this is, for example, data from our brain bank where we just looked at the cases with either intermediate level of ADNC or a high level of ADNC. And we said, how many of them have only plaques and tangles, right? And it's a minority of cases, only about 35% of cases, whereas the vast majority have a concomitant TDP-43 pathology, alpha-synuclein pathology, or both, right? And so I think it's very important to recognize that most cases, the vast majority of cases of Alzheimer's disease only do not have only plaques and tangles, and they have other comorbidities. This is a great study by Julie Schneider's group at Rush, where they looked at a community-based cohort, and they said um, um, they made some important observations. So this is on an individual scale. If you have a scale of how much Alzheimer's disease pathology you have here on the x-axis, on the y-axis is the probability that you have a diagnosis, a clinical diagnosis of Alzheimer's disease, right? So Alzheimer's disease uh, uh, clinical phenotype. And this green line is if you have only Alzheimer's disease in the brain, right? The more pathology you have, the more likely it is to develop Alzheimer's disease clinically, and that makes sense. These other lines represent when you have Alzheimer's disease and either hippocampal sclerosis or hippocampal sclerosis and TDP-43. And in the slide session, we'll talk about hippocampal sclerosis because that's a little bit controversial, how to diagnose this. But if we concentrate on what does TDP-43 do, you could see that for every level of Alzheimer's disease change you have, if you have TDP-43, you're much more likely to develop dementia, right? So again, TDP-43 is associated with more severe cognitive phenotype. It's actually associated with faster cognitive decline in the setting of Alzheimer's disease. So it's important to tell our patients, yeah, you have this amount of Alzheimer's disease, but TDP-43 and alpha-synuclein and cerebrovascular disease are often accelerants to the disease and important to document. This is another way to present the data. So again, this is in this paper back in 2019, where again, they're looking at more of a public health measure called attributable risk. So this is in a population, what fraction of Alzheimer's disease dementia can be attributed to various neuropathologies, right? So Alzheimer's disease is still the most important, contributing about 40% of risk. Vascular disease is very important as well, almost 25%. Late, which is limbic predominant age-related TDP-43 encephalopathy, and I'll talk a little bit more about this later, is a significant contributor to dementia, right? So 17%, and alpha-synuclein or Lewy body pathology or Lewy body disease is another 12%. So together, these four are probably the most important contributors to dementia in the community setting. Okay, so we'll run through those three important comorbidities. The first is vascular dementia or cerebral vascular disease. In isolation, they have different names: multi-infarct dementia, subcortical vascular dementia, and so forth. Classically, the medical school teaching is that this is a stepwise cognitive decline, meaning, you know, Aunt Millie was doing okay, but then, you know, in March, all of a sudden she took a hit and was doing worse, and that progresses. When I talk to my clinical colleagues, this is not actually a very common clinical phenotype. They very rarely see this very classic stepwise neurological decline. It could look very much like Alzheimer's or other dementias, but based on various cerebral vascular risk factors and MRI, you could see that you have these white matter hyperintensities around the periventricular region, along with other, you know, evidence of infarcts and so forth, that could lead to this diagnosis. Truthfully, neuropathology is just okay at diagnosing cerebrovascular disease, and part of that is because we're taking little segments of tissue from here and there, whereas cerebrovascular disease is really global throughout the brain. and also spotty. It's kind of stochastic. So I think we miss a lot of cerebrovascular disease. The best criteria that I could find are these VCING criteria. So I'm not going to talk too much about cerebrovascular disease, but I refer you to this paper to look for various things like infarcts, arteriolosclerosis, and other things, and how that might relate to cognitive phenotypes. The next important one is TDP-43 pathology. So TDP-43 was first discovered in the setting of frontotemporal lobar degeneration. FTLD is either caused by TDP-43 or tau protein. Rare cases can have other proteins such as FUS. But the classic pathology here is you develop these inclusions here, but you lose a normal nuclear TDP-43. You can see these other nuclei are staining with normal TDP-43. But in the setting of disease, you develop this inclusion and you lose your nuclear TDP-43. In our lab, we often use phosphorylation specific antibodies. And you can see here, those are more specific to the aggregates and don't stain the normal protein as much. And so this forms inclusions in frontotemporal dementia and also in motor neuron disease, so ALS. I'll skip that one. And but there are many different types of diseases with TDP-43. And this is just to highlight that it's not restricted to frontotemporal dementia and ALS. And importantly, probably the most the most common form of TDP-43 disease is what's called limbic predominant age-related TDP-43 encephalopathy. And so late is the presence of TDP-43 aggregates. You can see here, there's an image of amygdala stained with a phospho-TDP antibody. And this is seen in elderly individuals. It can be seen alone in the absence of Alzheimer's disease. It could also be commonly seen in the setting of Alzheimer's disease. And so there's this consensus working group where they define this disease. Here are just some higher power images. And the way that they stage this is you either don't have it. If it's restricted to the amygdala, you call it stage 1. And stage 2 is when it hits hippocampus. Stage 3 is midfrontal cortex. There are other staging schemes out there. So Julie Schneider's group has one, Keith Joseph's at Mayo Clinic has one that are a little bit more fine-grained. The important drawing line here is between stage 1 and 2. So stage 1 is typically not really associated with a cognitive clinical phenotype, whereas stage 2 and stage 3 are associated with memory problems and worsening of dementia. And the final comorbidity we'll touch on are alpha-synuclein Lewy bodies and Lewy neurites. So these are classically associated with Parkinson's disease, dementia with Lewy bodies, or Parkinson's disease dementia, where you could get, pallor of the substantia nigra. On H&E here, low and high power, you get these waxy eosinophilic inclusions that stain for alpha-synuclein protein in these dopaminergic neurons. But these are also seen in aging brains in the setting of Alzheimer's disease. So again, alpha-synuclein is not limited to Parkinson's disease and dementia Lewy bodies, but seen in many, many other diseases. In the setting of Alzheimer's disease, we use the McKeith criteria. This was best laid out in their third report many years ago, where you assess how much Lewy body pathology or alpha-synuclein pathology you have. I'll make a note that the amount of pathology you see with alpha-synuclein is an order of magnitude less than what you'd expect for like tau, right? So once I start seeing 1 or 2 Lewy bodies, I'll call that a mild burden. Anything beyond that is moderate. You could see that there's not that much here, but this is considered moderate and this is considered severe. And they defined originally 3 different variants or patterns, I should say. One is brainstem predominant, where it's predominantly in brainstem regions. The next is limbic or transitional, where you start to really creep into the amygdala, cingulate gyrus, and transentorhinal cortex. And then diffuse neocortical, as predicted, or as the name goes, extends to the neocortex. I'll say the 4th report was McKeith criteria was almost identical, but they just added another variant, which is amygdala predominant, meaning you see it mainly in the amygdala and really doesn't go from the brainstem up. And so your job when you're looking for alpha-synuclein is to find the appropriate regions to stain and try to subtype it into brainstem, limbic, neocortical, or amygdala predominant disease. So that was amygdala. Just to point out that Lewy body disease actually shows this very interesting pattern in the hippocampus, which you shouldn't think is an artifact or something, where it's really likes to hit CA2 more so than CA1. And you can see a higher power image where you have these fine neuritic processes in CA2. So this is real Lewy body alpha-synuclein pathology. And for some reason, it likes to hit CA2. And then just a few comments about how to report all these results, and then we'll go to some slides. So I kind of view the autopsy as the ultimate diagnosis, and it's our job as pathologists to kind of take the neuropathology, make a neuropath diagnosis, also understand the clinical syndrome, which is why I kind of emphasize that throughout my talk, and integrate that together with any, if you happen to have genetics, you happen to have biochemistry or anything else, to kind of put that all together. So the way we do it here at Penn is we actually have multiple sections, and it gets a little bit complicated, but we have a macroscopic gross description of the brain. We do a microscopic description, and here we're specifically saying what you see. We stained this, and we saw this, and we saw it in the cortex, we saw it in the hippocampus, whatever. And then we have a section where we just give our neuropathologic diagnosis. And so that could be, for example, high level of ADNC, and we give the ABC score, Lewy body disease, transitional pattern, or late in stage 3, let's say. We add a clinical pathologic correlation section, and that's where you're going to pull in all the clinical, neuroimaging, genetic, other data you have, and kind of say, well, this person had this phenotype. This is what we saw. That makes sense, or that means this is an atypical case, or whatever it might be, and then come up with a final integrated diagnosis. And we'll talk about that integrated diagnosis in a bit. So with that, I'm going to escape through this and then pull up some cases. Okay, so this is, let's see, a 71-year-old man. He had several years history of cognitive problems. He had actually problems dressing himself, often putting on his shirts backwards. His handwriting became very small. He had problems grasping and picking things up, and other vague, more visual spatial type phenotype complaints. He had some memory problems, but it wasn't that bad. And by formal testing, by cognitive testing, his visual perception function was really poor. He had some information processing and speed issues, and he did have some memory issues, but that was less prominent than the other findings. And so this is just an H&E of the hippocampus. Even just on low power, you could see how variegated and kind of wholly the cortex and the hippocampus is, right? So if we go into the cortex, you could start seeing these reactive astrocytes here, right? And you kind of get these empty spaces, which are interesting, right? It kind of looks like vague balls of pink. And that could either be reactive astrocytes kind of with their reactive processes out, or amyloid plaques. And in this case, actually up here in the hippocampus here, if we go into CA1, you could start to see the amyloid plaques even better. You could see here, let's zoom in. You could see it's kind of this waxy material. The neurons tend to be excluded. Sometimes you have some small cells. Here's some more here. There's one here. And what else? Depending on the H&E and the day, it can be difficult to see neurofibrillary tangles. And so this, for example, is probably a neurofibrillary tangle. It's kind of bluish, but the hematoxylin for this slide was not that great. Here's another amyloid plaque. And so if you do a tau stain, you could see everything brown here. This is a phospho-tau stain, is abnormal. On low power, the first thing you notice is it's really restricted to gray matter by large, predominantly. There are some diseases, and I'm thinking like, for example, cortical basal degeneration, which does not respect the gray-white boundaries. Alzheimer's disease is really a cortical or a gray matter disease. And when we go in, even on this power, you just start to see these balls, which are the neuritic plaques. I'll go out to neocortex to be. So here too, you could start seeing these balls. And so already I could call this CERAD C, because in neocortex, we have a severe burden of neuritic plaques. But you also have tons of neurofibrillary tangles, and all these squiggles in the background are those neuritic threads, which are also pathologic. In the hippocampus as well, Here, the neuritic plaques are even more prominent. You have these a lot of neurofibrillary tangles, all the neurites. And again, you're going to miss the vast majority of these if you're relying just on H&E. You can also do silver stains or thioflavin stains, for example. This slide is technically not from this case, but a very similar case just because we couldn't find the visual cortex. But here you see the tau stain again, filling the gray matter. This shows this very nice double bilaminar distribution. And so Alzheimer's disease classically has this predilection for these two layers of cortex. This is primary visual cortex. We know that because here you have the ventricle and the visual cortex kind of dips down to the ventricle. And here you could see all these neuritic plaques, and you start to see neurofibrillary tangles. And so this is BRAC6. Here's temporal neocortex. You could see again, it kind of looks like ratty, essentially kind of holy, especially in the superficial layers. You're kind of getting this sense that there are these pink clouds, which again are either reactive glia or neuritic plaques. If you do a tau stain, you again have this bilaminar distribution. You have a lot of neurites, neurofibrillary tangles, which I won't zoom in on. Just know that they're there. And then this is a amyloid stain. You could see that there are a lot of neuritic amyloid plaques. Again, you could see these more classic cord plaques or more just general compact plaques. You know, some are looking a little bit more diffuse, or maybe here, but by and large, most of these are dense neuritic plaques. And so I'm not showing all of it, but like in the hippocampus, this extended all the way into the cerebellum, and I showed you that image of the cerebellum having amyloid. So we know by thal phase, this is thal 5, which is an A score of 3. Amygdala here, again, amygdala itself tends not to show this kind of holy look to it that we see in cortex. And in the amygdala itself, it tends to be a little bit more solid. But when you go down, you start to see the reactive astrocytes. And you just get a sense that there aren't that many, as many neurons as you want. And the tau stain, sorry, this is just a ripped up slide, but you have a lot of tauopathy, tons of neurofibrillary tangles, all the neuritic processes. But importantly, this case also had a lot of synuclein pathology. And so here, with the alpha-synuclein state, you get Lewy body-like inclusions and Lewy neurites accumulating in the amygdala. This case also had some TDP43 in the hippocampus as well. So back to the integrated diagnosis, what I would potentially do for this case is my integrated diagnosis would be Alzheimer's disease, posterior cortical atrophy variant. Okay, so if you recall the clinical phenotype, which I was mentioning, the clinical classification was actually something called posterior cortical atrophy. That's which some people call this the visual variant of Alzheimer's disease, where it tends to hit the visual cortex prominently, and they have a lot of visual spatial issues. Memory issues are less likely. And so there are atypical or unusual clinical variants of Alzheimer's disease, the most common being this one, which is posterior cortical atrophy, or something called logopenic variant of Alzheimer's disease. And that's where you have poor speech output. You really don't talk much. You essentially become almost mute. And even though those aren't classic memory type phenotypes, those are most often associated with Alzheimer's disease. So I like doing this layered diagnosis where the histologic diagnosis, the main one is high level of ADNC, and I'll give the ABC score. I'll say that there's comorbid late, there's comorbid Lewy body disease, and give them their appropriate stage or types. The clinical classification is posterior cortical atrophy. Again, recognizing that most places don't have biochemistry, but we know that this is a 3-repeat and 4-repeat tauopathy. Had an ApoE risk variant, and this case actually also had a TREM2 risk variant. And these TREM2 risk variants now we know are associated with Alzheimer's or atypical Alzheimer's disease. I only have a few minutes, and so these last two cases just to show you an example of a couple of things. So this is a 77-year-old female, actually diagnosed with executive and behavioral issues, and so they thought this might be behavioral variant of FTD. This is a hippocampus. You could see again, even on low power, how ratty and holy and degenerated the cortex is. If we go in, you have these horrible looking vacuoles. They look different to me than what we see in prion disease. And you have these reactive astrocytes. Here in the hippocampus, if we start, around CA2, you could get these beautiful neurons, right? But as we move around into CA1, you can see really there's pretty severe loss of these neurons, right? Here, for example, you almost don't see any living neurons anymore. But what you are seeing are these pink structures, right? You can almost see it a little bit when we're back out a little bit. So there's some neurons, but more of these pink ghosts. And so those are ghost tangles. That's when a neuron used to be there, but has now died and the tau is just remaining. But you do see some of these neurons remaining. And so this hippocampus looks so degenerated that some people might call this hippocampal sclerosis. There hasn't been the inter-rater reliability for hippocampal sclerosis for some cases is not great. And that's because technically the definition says there's severe neuron loss and degeneration of the hippocampus out of proportion to the amount of tau. So if we did a tau stain, you could see that it's picking up all these neurofibrillary tangles, these ghost tangles. Again, the neurons are dead, it's just that the tangles are remaining. So for me, this is too much tau to call this hippocampal sclerosis. But it also highlights again that this is a case that they thought was behavioral variant of frontotemporal dementia, but really had Alzheimer's disease. And so AD can be very heterogeneous. And then the last case before I ran out of time, this is a 93-year-old male, developed significant memory problems, but it kind of lasted for 15-ish years or so and didn't progress a lot. It progressed some, but not a ton. And so in low power, you can see the hippocampus, and you do see that it looks degenerated and kind of wholly, even extending into the subiculum some. But here in the neocortex, just to compare to other cases, it looks not that bad, right? You don't get the holes. If we went down, we see normal neurons. We don't see a lot of reactive astrocytes. But here in the hippocampus, let me start back here. You could see like CA2 has a lot of neurons, but you could almost draw a line and now there's nothing, right? All you have are these beautiful reactive astrocytes and this vacuolar change. So this is potentially hippocampal sclerosis. When we did a tau stain, there was essentially no tau in this brain, or very little tau, I should say. So here's a tau stain. So there's a little bit of tau here in the hippocampus, so it's maybe like a BROC2, but you could see here in the areas that are degenerating, we don't have those ghost tangles. There's not much tauopathy. In contrast, we do have TDP43 inclusions, right? Sorry, let's go here. So the TDP43 can be kind of spotty, right? But you see that there are these little neurites and then some neuronal cytoplasmic inclusions here, and staining with a phospho-tau antibody or phospho-TDP antibody. So this is late or limbic predominant age associated TDP43 encephalopathy, and this is pure late. This is late without Alzheimer's disease, and classically these people have memory difficulties, and it could be severe, but tend to have a relatively slow course and tend to be very old. So this person being 93 fits very well with that clinical syndrome. And so with that, I will stop and just say that I kind of view the autopsy report as this final comprehensive classification where we want to take everything at our disposal, the clinical phenotypes, the morphology and the distribution we see under a microscope, and if you're able to, incorporating biochemical, genetic, and other type of information. And with that, I apologize, it's running a little late, but I'm happy to take additional questions and open up for everybody. Thank you very much.
Say, yeah. Thank you. That was absolutely fantastic. Do you want to maybe just take one or two questions?
Sure, absolutely.
Do you want me to read them or you want to read them yourself?
Let me open them and I'll start from the top. Thank you. Okay, that's just thank you. Okay. Do PSP and or CBD coexist with amyloid plaques? Yes, they can. And so in that paper where we mapped out the comorbidities, all the diseases tend to have at least some comorbidities, but not each individual case will. So it tends to be the older you are, the more likely it is to have Alzheimer's disease. Now, the difficulty thing is if you have a tauopathy like PSP or CBD, how do you BRAC stage that case? Because BRAC staging is really about the Alzheimer's disease tau, and that could be muddied with the PSP or the CBD tau. There are antibodies and tricks to do it. There are antibodies that stain only Alzheimer's, but not PSP or CBD. There's one called GT38 that's commercially available. I don't know if, like in a routine setting, whether it's that critical. Sometimes I'll just put BRAC staging is difficult because there's this other tauopathy. And so that's difficult. Again, there are also 3 repeat versus 4 repeat specific antibodies. And so if you do that, the Alzheimer's tau will be 3R and 4R positive, whereas the PSP CBD tau will be only 4R positive. So that could help. Peng Han, there are, yeah, so lymphocytes and Alzheimer's disease plaques. I have not done a ton of staining. I wouldn't be surprised if there's some, but there's not a lot. I don't, yeah, there's not a lot. So I'm not, I'm not exactly sure the role of lymphocytes in this disease. And Iben says, when you have a case of Lewy body pathology in the amygdala and it splits mildly to the hippocampus cingulate, do you stage it as McKeith limbic, even if it does not have remarkable brainstem? Yeah, I would, kind of depends. So I would probably call that amygdala predominant. For me, limbic, let me see if I still have the McKeith here. And then let me share. Okay, so if I move this, if you look at limbic, right, you're starting to get amygdala and cingulate, but you can see that you have to have at least some in the brainstem, right? So amygdala only will, limbic requires at least some brainstem pathology, whereas amygdala predominant does not. And then your second question, sorry, I have to roll back. Regarding RTAG, yeah, I didn't talk about RTAG much. So RTAG is tau that builds up in astrocytes. They could be subpial or periventricular. Right now, I describe RTAG in the microscopic description. I don't necessarily make a separate diagnosis. Most series don't find a sizable clinical pathologic correlation with RTAG. Leah Grinberg looked very nicely in region-specific RTAG, and so there might be some effect on cognitive phenotype, but I think it's relatively subtle. So I describe it, but for now, I don't make a separate diagnosis. And then how do I describe CAA? Yeah, I'm not consistent. There are different staging types, as you nicely point out. Right now, I kind of say mild, moderate, severe about amount of CAA. We're thinking about going back and staging them all, but that's just, I think it's important, and there are different patterns, but I personally haven't done a great job of CAA and probably should. And do you try to perform ABC and other tauopathies? And I mentioned that as well. And then Joseph Fulmer, what are your thoughts on a few questioning the role of plaques and tangles in AD? I think you have to draw a line between mechanism and diagnosis. So I don't think there's any question that plaques and tangles are diagnostic of Alzheimer's disease. I think I could give you my personal views that I don't think amyloid causes degeneration itself. I think it has to induce tau to cause degeneration, but that doesn't mean it's not involved. I think the preponderance of evidence says that it's involved, but I think it's healthy for scientists to question. Thank you, Kara. Thank you, Marta. And that's it.
Thank you, Dr. Lee. Thanks again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. I have also entered it into the chat box for this meeting. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based off your credentials. The PowerPoint slides and recording will be posted to the AANP website within the next week. Thanks again, Dr. Lee, for an excellent presentation, and that concludes the session for today.
Hi, everybody.
Thank you.